start on it. And then we're going to review for our first lecture midterm, which is on Wednesday of this week. A little bit more about that in just a bit. But let's go ahead and talk about the knee joint. So this chapter on joints or articulate, boy, that's really bright. Is that bothering you guys too? Yeah, oh. I'm going to bring my cool sunglasses from Dollar Tree. Huh? There's switches? There's no dimmer over here. Okay, hold on. Okay, bear with me. Oh, that's on red. Oh.
Or maybe that one off tonight. That one?
Yeah. Oh, do you want to do that? So this is a little bit better.
Okay, whenever you're
So
ready.
I'm gonna do it. No? Okay.
Yeah.
That's better? You guys are gonna fall asleep. Is that better? Yeah? Really? Really?
Yeah.
So show of hands who thinks this is better. Okay, like in the movies. Oh, I should run popcorn. How many of you are not okay with this? See, I don't know. I'm not okay with it either. Oh my gosh. Oh my god. Okay, hold on.
You can't fix the heat, and only fix the light.
Yeah.
No. That would be too much.
I think it should be set so it doesn't stick on the bottom.
Well, isn't that fun? Okay, well, let's get through this as painlessly as possible, but I have some good news for you, which I just made a decision. For our lecture midterm on Wednesday, why don't we make it open book? Whoa! What? Oh my God! Who's not okay with this? Anyway, because I want to make this class as interesting as possible, and I hope you're having fun learning stuff, but I'm faced with all sorts of, should we say, infrastructure situations, and lack of heat and so forth. So, I bought the little, heaters and so forth. Maybe I should bring my husband, who's a retired contractor. He's not union anymore. Oh, okay. Anyway, so I'm doing what I can. So why don't we do this? For the first lecture midterm, it's still going to be 1 hour long, right? From 9:15 till 10:15. The main thing is to make sure that you have a good, strong Wi-Fi spot. If you want to take it at home, that's fine. If you want to take it on campus, that's fine. If you want to take it on the third floor, hanging out with me, that's fine too. It would be either in the lab or in the BRC. So the main thing is to make sure that you log on right at 9:15, right? And and I'll send an announcement on. Wait, what is today?
Monday.
So tomorrow to remind everybody to log on. So how does that sound to you? We're good? Okay, yay. And I apologize profusely. I've been at City College for a couple of years, 32, but, it's really the best school ever, but again, sadly, we don't have the money. So I'm going to try to become a billionaire. Maybe is Besso single? I don't know. So, oh, he is actually, right? Okay, so here we go. So before we get into the review thing, let's go ahead and talk about the knee joint. On Wednesday of last week, when we talked about the chapter on articulations or joints, that's chapter 9, I believe, we talked about the 3 types of joints, and those would be fibrous, cartilaginous, and synovial joints, right? And also on Wednesday, we talked about the main features of a synovial joint. And then all synovial joints are functionally called what? Diarthroses, thoroughly movable joints, right? But this is the thing to remember, and that is that the only synovial joint that we covered in some detail would be the knee joint, right? So they talk about the elbow joint and all the other stuff. Knee joint, the only synovial joint that we're covering in a lot of detail. And the reason for that is that it's probably arguably one of the more complicated joints. It's one of the few joints that has, you've heard of the menisci, right? Those are the articular discs. Some of you shared with me had, meniscus problems and things like that. And so it has a lot of cool parts to it. So yes, the knee joint is the only synovial joint that we're going to talk about. Also on Wednesday of last week, we talked about the different actions possible at synovial joints. Make sure that you look at those. There'll be a couple of questions on, actions. For example, what is an action which causes decrease at an angle of a joint?
Flexion. Flexion.
Flexion, exactly, and increase would be extension. But you mentioned adduction and abduction. So adduction back to the midline, right? Abduction away. And then I'm going to have this action, supination. So that's when you rotate the forearm so that the palms face anteriorly, supination. And the opposite would be pronation. Okay. Then, at the knee joint, what are the actions at the knee joint? Well, we have to consider those carefully. So, at the knee joint, and considering the quads, the quadriceps femoris group, right? Quads in the front, the quads will act on the knee joint to extend it. It also, the opposite, the hamstrings would be flexion. So we've got flexion and extension at the knee joint, and really very minimal rotation, at the knee joint. So the slides are from your book, and again, simplified. And this would be an anterior view of the knee joint. The knee joint is a lot about various ligaments. So for example, up in front, let's do some of our old friends. We've got the patella. Here are the quads, quadriceps femoris group, and they have a common tendon known as the quadriceps tendon, right? Here's the patella, and distal to the quadriceps tendon would be the patellar ligament, which attaches to that bump on the anterior tibia, tibial tuberosity. Exactly right. So the primary ligament on the front of the knee would be the patellar ligament. Also remember naked person, right? I'll have several questions on naked person with respect to directional terms. Because in the anterior, the front of the knee is also the patellar region. Back of the knee would be the what? Popliteal region, right? And over here in the posterior of the knee, we have the popliteal ligament. So those two terms also reflect the directional terms. So just for fun, fill in the blank, please. The popliteal region is what to the patellar region? Give me two possibilities. Dorsal or posterior. Or switch it around. The patellar region would be what to the popliteal region? Anterior or ventral, right? So look at all of the different options. So posteriorly, the main ligament of the knee joint is called the popliteal ligament. And popliteal ligament is quite extensive. There's different parts to it. I do want you to remember the two main subportions, two main components, not the only, but the main components of the popliteal ligament would be oblique, coming in at an angle, and the arcuate. One more time, popliteal ligament, posterior, two main parts, oblique, and the arcuate. Because when you start looking at arthroscopic or full knee surgery operations, you'll talk about some of these main ligaments of the knee joint. All right, but now we need to go back to the anterior view because, and I didn't label all of the ligaments, we're just doing the main ones. So we have one in front, one in back, patellar, popliteal. And then we have two on either side. So here's the tibia, here's the fibula bone, right? So on the medial aspect, remember the tibia is medial, we have the medial collateral ligament or tibial collateral ligament. So that's good to remember as well because that will remind you that the tough tibia is medial, skinny fibula is lateral, right? Conversely, on the lateral side, here's the fibula. We have the fibular. Where's it located laterally, right? Fibular or lateral collateral ligaments. Okay? So we have front and back, medial and lateral, and then if you take a look at an anterior view of, a lateral view of the knee joint, we're going to also identify some intracapsular ligaments. They're not spelled out here, but this is more for the bursa. But just recap, patella, superior to it would be the quadriceps tendon. Distal would be the patellar ligament. Here would be a good question. The patellar ligament is an extension of the what? Quadriceps tendon. It's really the same thing, right? Continuing over and distal to the patella. Then, what else do we have here? Inside the capsule, let's go back to this, I'll go back and forth. So, inside the joint capsule, again, this is a synovial joint, so we have a capsule, we've got the fluid, the synovial fluid right there, and we also, in the knee joint, some other joints as well, but not all of them. In the knee joint, we also have ligaments inside the knee joint. And those are called what, please? Intracapsular ligament, inside. And those are, let's see, ligaments that kind of cross each other, forming an X-shaped kind of thing, cross, and those are called the what, please? The cruciate ligaments, crossed over like an X. And there's one in the front. What would you call the anterior cruciate ligament?
The anterior cruciate.
And the other one would be the posterior cruciate ligament, ACL and PCL. Anybody watch that game that they had on that we weren't in? Is it Super Bowl? Whatever. Anyway, so if you watch football or any sport, ACL and PCL, ACL, PCL. Which one do you hear about more frequently, ACL or PCL? ACL, because that's the one that is more likely to be injured or torn. ACL. So you rarely hear about the PCL, and that's because of the attachment sites and the physics of the knee joint. Okay, so we got the medial and the lateral intracapsular ligaments. Again, anterior, look at the anterior cruciate ligament. Little skinny guy right here. Look at the big one in the back, posterior cruciate. Posterior PCL is much stronger, therefore not as likely to rupture. Then, by the way, I was doing this last semester. What's all this business right here? So the quadriceps has been cut, right? So we're gonna have this thing hanging down, right? Should have been reattached. So then we have on the fibula, what do you call these guys on the distal femur? Medial and lateral, just the bony portions would be the condyles. Perfect. So these are the two femoral condyles. And we have a lab exam coming up next week. Oh, the nightmare never ends. But we'll be fine. We'll be fine. The midterm. I can't believe I did open book. Did I say that? Oh my bad. Anyway, let's see what happens. So, so you could thank the scaffolding guys. So anyway, here's the femoral condyle, medial, and it articulates to the medial condyle of the what bone? Tibia. Whereas this is the lateral condyle of the femur, or lateral femoral condyle. This is more for the lab. And that articulates to the lateral condyle of the tibia, right? Now, check out this four-wheel drive situation right here, right? So the femoral condyles are huge, like big old wheels, right? Tires. And if you have a four-wheel drive, you need traction, right? So that becomes a problem because look at the proximal portion of the tibia. It's kind of flat. It's got those intercondylar eminence things, right? But it's kind of flat. So the tibial condyles are flat-ish. So therefore, in the knee joint, there are these articular discs. When you think about a disc, what kind of cartilage would be fibrocartilage? And the articular discs of the knee joint are the medial and the lateral menisci. Yeah, one meniscus, two or more menisci, right? So singular and plural. And again, articular discs are fibrocartilage. They're present not in all joints, in the knee joint. And the TMJ also, I won't ask you that till later. But in the case of the knee joint, take a critical look at the menisci of the knee and their shape. They're kind of half-moon shaped-ish. Why do we need the menisci? To provide a better gliding surface of the femoral condyles over the otherwise flat proximal end of the tibia. So they deepen the articular surface, right? Because I mean, the proximal tibia is flat, but check these guys out. So here's the medial meniscus. See how it's fatter laterally and then kind of tapers off towards the midline? Same thing here. So the shape of the menisci serves to deepen the articular surface of the tibia, provide a cushioning effect, right? And to facilitate that flexion and extension at the knee joint. So on the menisci, how many are there, please? There are two. They are articular discs, therefore what kind of cartilage? Fibrocartilage. And they deepen articular surfaces, facilitate movement of these very large femoral condyles over the otherwise flat tibia. And then here is a superior view of the knee joint. So we're looking down at the tibia. So this would be the tibial tuberosity, and these are the menisci, so the medial and the lateral meniscus. These crossover intracapsular ligaments are called what, please? Cruciate, anterior and posterior cruciate ligaments inside the capsule. And then articular cartilage. I want to make sure you're clear on this. So as far as types of cartilage tissues that will be on the midterm, right? So we have, if in doubt, we go with hyaline. We have the embryonic skeleton. We've got the epiphyseal plates, costal cartilages, most of the external noses, hyaline cartilage, most of the larynx. So that's hyaline. Then we have elastic cartilage. Locations, please. Epiglottis, right? And ear canal. Think of the E's, right? And then we have fibrocartilage. Fibrocartilage, what's the word would be disc, right? Intervertebral discs, interpubic disc, the symphysis pubis as well. But the articular cartilages, not discs, not the menisci, are hyaline cartilage, right? So those would be depicted in kind of a darker blue color here, and the lighter ones would be menisci, articular discs, fibrocartilage. I want to go back to this slide, and here, let's talk about bursa. So what is a bursa? A bursa is sort of a synovial bag full of synovial fluid, right? And these bursae are external to the joint capsules. They're outside, right? So, and the knee joint, it's got, I think, at least 6 different bursa. Not all of them are pictured here. So we have the suprapatellar, infrapatellar, subcutaneous, prepatellar bursa, all in kind of in green. Take a critical look at the slide. Which bursa do you think, clinically speaking, would be the most likely to be injured, like in a fall or something like that? Subcutaneous prepatellar bursa, right? Because in a falling situation, or you're going to perhaps, I don't know if really I guess puncturing would be a condition, but also it would irritate the synovial membrane, and then that would activate the production of even more synovial fluid, right? So the one mostly affected would be this subcutaneous prepatellar bursa. Easy to remember, the bigger word, you should be happy. Under the skin, subcutaneous, in front of the patella, and it's a bursa. What do you call elongated sheets of synovial membrane going around tendons? I pretty much gave that away. Tendon sheets, right? But structurally, they're pretty much similar to the bursa. They're bags of synovial fluid, so therefore you have that synovial membrane with a bunch of fibroblasts and other elements forming that viscous synovial fluid. Let's see. So to wrap up the knee joint, we have an anterior ligament. In the front is the patellar ligament. In the back, we have the popliteal ligament. And I think, unless it was one of the practice questions, popliteal ligament has 2 main components, oblique and arcuate. Look how extensive this stuff is, right? And then we have, I like this slide because it's pretty simple. We have the medial collateral, what's another name? Tibial. And lateral collateral or fibular collateral ligament. What do you call the intracapsular ligaments? They cross over, so they are cruciates. The anterior and posterior cruciate ligament, ACL and the PCL. Alrighty, and then I have everything pretty much summarized for you on the knee joint. Any questions on the, yes?
Yes, on the first slide you had where it was showing the anterior with the ligaments, the 2 to the side of the patella, would those be part of the quadriceps tendon, or is that something different, distinct from
I see. That's a great question. So when we talk about origins and insertions of the different muscles, it gets complicated. So the easiest way to remember the insertion site of the quads, by the way, quads, 4, right, elements, and all except for one start not at the hip but at the femur, proximal femur. But one of them starts at the hip. So the quadriceps group, quadriceps femoris group, as a group, and this would be a good question on second lab exam, I'm not sure when we talk about only attachment sites but actions, what would be the main action or actions of the quadriceps? So when you think about actions of a muscle, that muscle is doing what? Is it contracting or is it stretching? It's contracting. When a muscle is stretched, it's not doing work. It's passively being stretched by the opposing muscle, right? Mm-hmm. So we got this guy right here, biceps brachii, right? And in the back, I don't think I have one, but it should be there. Triceps brachii. That's a tough one to exercise. Oh, yeah. Anyway, biceps. So when the biceps contracts, that's when it's doing work, right? When it's stretched, it ain't doing nothing. Who's stretching the biceps? The triceps brachii, right? So muscle actions, visualize what that muscle does when it's contracting, right? So when you contract the quads, remember one of them starts at the hip, right? The other 3 at the proximal femur. More about that later. They all insert, the short answer is into the quadriceps tendon. and there's some lateral components to that too. Yeah. But so then, when the quads, and I'll take your question in a second. Here I am. Hurry up before I break something. Okay. So here I am. Here's the quads. What are the quads doing?
Extending.
Extending what? What? Hurry up.
Like this somewhere else.
The knee joint, right? But ooh, look, it's starting at the hip. It's flexing the hip. Flex the hip and extend the knee, right? Whereas the posterior, there's 3 of them, or 4, depends on who counts. Little hamstrings, you've heard of those, right? We got the biceps femoris, semi-typical. Anyway, when those contract, and this I'm really gonna fall. The scaffold, we need scaffolding people. Okay, so here are the hamstrings in the back. What do the hamstrings do? Well, opposite to the quads, right? So they will extend the hip and flex the knee, right? Is that cool? Yes.
So it's just as it's like
Oh,
posterior, anterior, laterals out.
yes,
Just leave it like that, posterior.
exactly. So let's actually, thank you for reminding me, Travis. We're going to do the directional terms, medial, lateral, and that kind of stuff. All right? Shall we review?
Yes.
Yay! I'm exhausted already. I'm so stressed out. Anyway, so, review. So this didn't come out really well over here. And a couple of things on the exam, just logistics. Please find a really good Wi-Fi zone, right? Strong internet. Library could be an option. I'll be around. It's not like I'm going to be in Starbucks or anything. I'm here at 7:30. Anyway, but I'll be in my office if you have any questions or whatever. The BRC is a good place to take the exam, or if you want to let me know, I'll be in my office. I could let you into the lab, whatever you're comfortable with, right? If you don't have anything else going on campus on Wednesday, I would take it from my bed. I don't know, whatever you want to do. Now, it's on Wednesday, so Wednesday, folks, what do we do? Well, if you're going to be on campus anyway, take it here. If you are in close commute mode, you could take it from home, whatever's more comfortable for you. We will have lab on Wednesday. Now, all of this weekend labs, what we're doing is reviewing, right? So the Wednesday lab goes from, 10 after 11 till 2. Rarely anybody stays after. A couple of people. We hung out, right? Anyway, so if you come in a little bit later to lab, that's okay too, because all we're going to do is have an open lab for review. Okay? If you have any issues with the scheduling or whatever, let me know. And we're Wi-Fi. Oh, the other thing is browsers. So Safari kind of is not always friendly. So Google Chrome is the preferred browser, right? So you could download that. Safari cut me off. I was taking an exam, I'm taking a class. I'm so stressed out too. I'm taking it, oh my God, I have to learn how to code. Do coding on a computer. There's numbers involved. Anyway, you know how I am. So, and my it cut out. So Google Chrome is the way to go, right? Apparently Firefox might be a good one, but Google Chrome is the, did you have a?
Just going to say, in the BRC, even like the connected computers, they time out a lot during Canvas, like using Canvas at all.
Yes.
So I wouldn't use those computers for an exam.
Exactly. Thank you for reminding me. So the computers in the BRC, surprise, surprise, aren't great. So what I was thinking about using the BRC is not to use the computers, but to physically be there. And I think Wi-Fi is still pretty good there, right? Correct me if I'm wrong. So I would not trust any of that stuff, right? So that's the format. And log on at 9:15, right? And it will time out at 10:15. Do not use books. Oh, wait, we changed that. Oh, she's happy. Okay, all right, so we'll do that, all right? So I expect a lot of perfect scores, all right? No pressure. So here we go. Okay, as far as the format is concerned, right? There's 50 questions. 50 questions, you get 2 points per correct answer. I do not lock the questions, which means that you could go back, right? So I did a lock exam. I took a lock exam last night and I cried. So you can't go back, right? You will. Yes, you go back. Now here's the thing: the open book thing. Sometimes that works against you. Study for the exam as though you cannot use any notes. That's the way to do it. Otherwise, you're going to be, calling a friend. Don't call them; they would know. Or Googling stuff, not okay, right? Study for it as though there's no notes or anything involved. Okay, straightforward, 50 questions, multiple choice, easy peasy. And then as far as the content is concerned, it's about 8 to 9 questions per chapter, right? And so the chapters would be, chapter 1 would be the intro. And what I think I'll do is, I'll go chapter by chapter and ask for if anybody has any questions on any chapter. So, chapter 1 is the intro, and Travis was talking about directional terms. Please, please, please look at the naked person, right? Know their body parts, the regions, and then we apply directional terms, right? So, for example, superior, cranial, caudal, cranial, cephalic, inferior,
Dorsal.
or caudal. Okay, so then Travis was talking about medial and lateral, right? So if you picture like an imaginary line going right down the middle of the body, anything closer to that midline is said to be medial. Further away would be lateral, right? Now, always, and the pollex and the hallux are probably going to be on there. So always we are assuming what? Anatomical position. So the pollex, this guy, is what? To its 5th digit. Lateral, because we're not going like that. We're going. And big toe is the hallux, and the hallux is, what's happening there? You close it? Oh, thank you. The scaffolding guys are still there?
Yeah, it's loud.
We need coffee, we need donuts, popcorn. Okay, and so the hallux would be medial to its 5th digit. All right, so then a couple of other things, and we talked about this in lab as well, as far as directional terms. Fill in the blank, please. The antebrachium is what to the brachium? Distal. With respect to the hands, the I'm not going to be up there, right? So the metacarpals are what to the phalanges? Proximal, right? Okay, did we miss anything else? Okay. Planes of section, right? So what do you call a section or cut that yields an anterior and a posterior? Frontal or coronal, right? One that yields externally equal right and left would be mid-sagittal, perfect. Anything off-center would be parasagittal, right? Let's see what else is there. Oblique at an angle. Cross, horizontal, transverse section. Cut right here, the 2 parts would be superior and inferior, right? I think I got most of those sagittal. So directional terms. Body cavity, so subdivisions, some basic stuff. Pathology, study of disease. Histology, study of tissue. Cytology, study of cells. Okay. Then we have microscopic. Okay. We have light microscopy, right? We have electron microscopy, 2 parts. We have scanning and transmission, right? Transmission, uncut sections, just a 3-dimensional view, right? Light, L for low resolution, right? And the others would be high resolution, right? So, artifacts. I think I'm going to use that term. Why not? Artifacts would be distortions. So, anything that's subjected to any chemicals, whatever, will have distortions, and those are called artifacts. So, maybe a word like that. Microscopy, regional terms, got that one. Levels of organization, we got those. Now, organ systems and components. So, for example, which organ system serves to break up nitrogenous wastes and includes the urethra, urinary bladder, that pretty much says.
Urinary.
That would be urinary system. I just gave you the answer. Okay, how about which organ system includes skin and all of its appendages? Starts with an I in the integumentary system. Okay, so maybe one question on systems. Now, body cavities. Somebody still had a question, which is a really good question. So we've got the dorsal body cavity, cranial and vertebral, easy peasy, right? And we have the ventral body cavities, much larger, divided by the what muscle? Diaphragm muscle, into a superior thoracic and inferior, we'll just call it abdominal pelvic. And then kind of throw the peritoneum in there. Then mediastinum, to be clear on the mediastinum. So the mediastinum would be the space between the two pleural cavities. Between the two pleural cavities. All right, and kind of like nesting boxes, right? What do we have within the mediastinum? Well, the heart, which is within its pericardial cavity, right? And then we have part of the esophagus and the trachea and the big vessels. So all of the stuff that is located between the two pleural cavities, that space is the mediastinum. Again, it has the heart within its pericardial cavity, what I mentioned, the trachea, windpipe, esophagus, the gullet, the big vessels coming off the heart, mediastinum. Don't worry about peritoneal and intraperitoneal, we'll get to that later. But, I just reminded myself. As far as ipsi and contralateral, right? Ipsi, same contra, opposite, right? So I will ask maybe one question about that using the main organs of the abdominal cavity. So obviously it would be something like the ascending and descending colons are what? Ipsi or contralateral? Contralateral. How about the liver and the spleen? Also contralateral. But how about liver and the gallbladder? Ipsilateral, right? So I think I pretty much covered all of that. Just some of the basic structures within the abdominal cavity. Alrighty then. Any questions on chapter 1? We're going to have to move it, but no, I have plenty of time. Yes?
I just, when you were talking about the fingers and abduction,
Yes.
that's from a midline, but that's the only time the midline applies here. Otherwise, it's always the body.
Yeah, the
is that
midline
right?
of that structure. That's a great point. So, away and abduction, this adduction, right? So in this case, that midline would be in the middle of that upper limb, right? In the midline. So back to the midline. So fingers together would be adduction. Fingers away from that midline. In this case, yeah. So sorry, I wasn't clear. So midline of the body, right? So from that
So
perspective,
it's function versus like standing still. So when it's action, this can be a midline, but when it's just anatomical position, this is no longer a midline.
and it's still a midline.
So this would be medial lateral, like for example, in that case, then would this be medial to, or would this be medial to my
The
thumb?
what? The second digit?
Well, I'm saying if the midline applies
Uh-huh.
there, then technically the second digit would be medial to the thumb, even though the fourth digit would be medial to
Yeah,
the
it is.
pinky.
Absolutely.
It is.
Yeah.
Okay.
Yeah. So, confused? I'll tell you the questions. Fingers away. Abduction. Fingers together. Abduction. And as far as you mentioned, like the proximal and distal, that's important, right? When you are considering two body parts on the upper or lower limb that are not at the same proximity to where the whole thing attaches, right? So then you use proximal and distal, right? When the two parts that you're considering on the upper and lower limbs, on the appendicular skeleton, and they're kind of equidistant, right? So who's going to measure? Is the thumb closer or, I don't know. So then you use lateral and medial, right? So, but as far as actions, here's the midline of the arm. Just take the arm apart, right? So away from that midline would be abduction towards the midline would be abduction, adding back. Okay, good question, thank you. Anything else on chapter numero uno? No. Okay, let's move along to chapter 2, which is on the cells. Okay, so chapter 2 on the cells. Make sure that you look at the different components of the plasma membrane. Bless you. Phospholipid bilayer. We've got inside the phospholipid integral proteins. Most of those are transmembrane going right through, and many of them have channels. I know some of you are taking physiology. There's a lot of stuff going on there. Peripheral would be on either side, either on the external portion of the membrane or external part of the phospholipid or on the inside, right? Some of them are receptors. Cholesterol, what does it do? Stabilize, right? Then we have the sugar coating on the outside, and that's the glycocalyx, which would be sugar to fat, glycolipids, and sugar to proteins, glycoproteins. And those act sometimes as a biological marker to tell other cells what the cell is all about and so forth. Probably not, maybe some receptors to some extent. Most receptors are proteins, by the way. Okay, then we have movements across the membrane. So cell eating is phagocytosis, right? So you internalize, you're making those pseudopods, you're bringing in and making that little phagosome, right? Phagosomes, here's another question. Phagosomes containing stuff that needs to be broken down, phagosomes will merge with, starts with an L, lysosomes, right, to break down whatever it is, could be bacterial component, whatever it is, right? Cell drinking is phagocytosis, right? But internalizing just molecules of water would be osmosis, right? And that would be down a concentration gradient. All the gory details in physiology, right? So from an area of high to low concentration. And that would include diffusion. We just go with simple diffusion. If you're taking physiology, that's what we're talking about. So little tiny molecules go from an area of high to low concentration. That's more or less correct. Okay. Then we have bulk transport. And in those cases, we are using what? Proteins. Protein carriers, right? And then we have, transport mechanisms, proteins, right? But bulk transport, remember you go to Costco, right? And either you bring stuff in that is called endocytosis, right? Endocytosis, and the opposite would be exocytosis. All right. What is the most specific type of endocytosis? Long name. Receptor mediated endocytosis, receptor mediated, right? So we got those fishing poles, right? Receptor mediated endocytosis, the most specific. You're internalizing a specific cargo of things. They're called ligands, but we don't care. Let's see, what else do we have here? All right, so then cytoplasm. All right, so cytoplasm includes the background kind of liquidy jelly thing, cytosol. Okay, cytosol is not part of the cell membrane, cytosol, cell solution. And there we have permanent components, little organs, or called organelles, and inclusions. Give me a couple of examples of inclusions. Lipid droplets, right? Glycogen granules, melanin, right? So they kind of come and go as needed, right? As far as organelles are concerned, please note the main ones, what they look like descriptively, and what they do. So let's start with rough ER. Rough ER, ribosomes, what does it do? Protein synthesis, right? Smooth ER, got no ribosomes, right? So it's not protein synthesis, but lipid metabolism, detoxification, calcium storage in muscles. If you're taking muscle stuff, physiology, calcium is everything, right? Okay. Golgi apparatus. What does it do? Amazon Prime, right? So that would be Golgi apparatus. What does it not do? It doesn't make proteins, right? But it packages proteins, right? Maybe slight modification. Peroxisomes are specialized more in the liver, so, and kidneys. I think I wrote down spleen. Thank you for my correction, but I'm not going to do that. Hydrogen peroxide. Acid hydrolases are contained within what? Lysosomes, right? And lysosomes, Lysol spray, I pretty much present everywhere. Centrioles. Centrioles composed of what? Microtubules, right? And those microtubules then form the mitotic spindle, right? Let me see something. Organelles. Huh? Yeah, just organelles. Oh, mitochondria, my favorite. Okay, mitochondria. My bad. Mitochondria, two membranes, right? The inner membrane is thrown into folds known as cristae. All the stuff inside is the matrix. And what do mitochondria do? Three letters? ATP. ATP, thank you for the mitochondria. Okay, then we're going to move into the nucleus, nuclear envelope. How many phospholipid layers? Four. Oh, yes. Two membranes, four phospholipid layers, right? We got the nuclear pores, and we have then within the nucleus the darker staining, beautiful nucleoli. What do nucleoli do? They make the ribosomes, right? Make the ribosomes. They're the two subunits. Nucleoli make ribosomes. All right, then here's another question. Please write this down. In a non-dividing cell, the cell is in what phase? Between divisions interphase, and inside the nucleus would be chromatin. Beautiful. Non-dividing cell phase is, one more time, interphase, between, right? And in interphase, the DNA and protein are kind of dispersed in the form of chromatin, interphase chromatin. I always forget, there's a lot of things that sound familiar. But chromosomes would be the X-shaped thingies, right? Make sure that you look at all the slides in the lab. There'll be no pictures and no pictures on the midterm, just words, right? But there's some, overlap. Absolutely. This week in lab, I already set up a little mini practice lab practical for everybody, right? One lab at a time. Don't you all come over here. Anyway, so nucleus. All right. So that's about it on the cell, I believe. Cell cycle. Okay. So please note interphase. We talked about that. Then we have the PMAT, prophase. And in the middle, lining up in the middle would be metaphase, all the chromosomes, right? And then they pull apart, that would be anaphase, and then the last part would be telophase, the reverse of prophase, right? And cytokinesis is kind of a different process. It occurs concurrently within the last two phases of mitosis. Cytokinesis would be the division of the cytoplasmic content. And that doesn't have to be a perfect division. Mitosis, we're parceling off the parent cell into two children cells, right? Mm-hmm. That has to be a perfect process. Real quick, anything on chapter 2? That's good. Okay. Chapter 2 is cool. Then chapter 4 is on tissues, epithelium, borders, and so forth. Lateral border specializations, right? So which lateral border specialization serves as a barrier to permeability? Goes all the way around, starts with a T, tight junctions, right? Tight junctions all the way around, right? Then we have these little spot adhesions, desmosomes. And what are my favorites with the connexon, cell-to-cell texting? That would be the gap junctions. Tight junctions all the way around the cell. Okay, kind of cements the cells together to some extent. Desmosomes spot little buttons, and cell-to-cell communication, gap junctions. All right. Then, if an apical surface of an epithelial cell If it has structures that are involved in movement, cilia. And inside cilia, we have microtubules, right? They're also part of the cytoskeleton, right? But if the apical surface things just simply increase surface area, microvilli, right? So like in the absorptive epithelial of small intestine and things like that. The bottom, the basal surface of the cells are sitting on the basement membrane, 2 parts to the basement membrane. It's non-living, right? And would be basal lamina, and underneath that would be a whole bunch of little reticular fibers, right? Reticular layer. So basal lamina and reticular fibers. All right, so then make sure that you look at the different types of cells. So we talked about, well, let's see, back to epithelium. What's the thinnest possible, please? Simple squamous for diffusion, right? Then we have 1 row of cells, but some are short, some are tall. Pseudo-stratified epithelium, right? That's lining most of the respiratory system. Lining most of the kidney tubules would be a simple cuboidal, simple columnar, most of the digestive system. What is the kind of stretchy-ish epithelium accommodates for volume? Starts with a T, transitional, goes from a kind of thicker to a thinner, and that would be in the urinary system primarily, urinary bladder, the ureters, and the urethra. So look at classification, CTP. CTP, we've got cells and matrix, right? Within the matrix, 2 components. Within the matrix, we have ground substance, and embedded in there would be fibers. 3 types of fibers. If in doubt, you go with hyaline cartilage, which has collagen, right? Collagen fibers, right? Reticular fibers, and the stretchy ones are elastic fibers. So matrix, ground substance, and fibers. This is all non-living stuff. Cells, we've got fibroblasts, so kind of a catch-all term might be which cells form most of the matrix. Fibroblasts, right? Then we have the big walking eaters, then we've got macrophages, we have mast cells, histamine and heparin, we've got plasma cells. Did we talk about plasma cells? Activated B cells, they secrete antibodies. No? Okay. All right, so then what do we have? Glands, endocrine and exocrine. Goblet cells. The only example of a unicellular exocrine gland. So exocrine ducts secrete a bunch of stuff, but they do not secrete hormones. Endocrine into the bloodstream, and the only products that they secrete would be hormones. Obviously, a whole bunch of different hormones. Chemical messengers. Alrighty. So let me go right into the other chapters in tegumentary system. Make sure that you differentiate between thick and thin skin. Not only locations, but in thick skin, there's an extra layer in the epidermis, stratum lucidum. You guys are awesome, right? So epithelium, epidermis would be a keratinized, stratified squamous epithelium. Main cells are the keratinocytes. Stratum basal, we've got those undergoing lots of cell division, and we've got also the melanocyte cell bodies and those tactile cells, right? And then we have spinosum, granulosum, lucidum in thick skin. Look at the different glands associated with the skin. So we've got the pseudoriferous or sweat glands. The regular ones are eccrine. The ones activated at around puberty would be apocrine. Remember the axillary regions and so forth. All right, so I just popped something popped into my head. Superficial and deep. The epidermis is superficial to anything else, right? Or you could say that the spinal cord is deep to the skin, something like that. Superficial and deep. All right, so then what do we have here? So we're still on here, sebaceous, look at that, sebaceous alveolar morphology. I think I have that, holocrine. So the sebaceous or oil glands, first of all, they're associated with hair, right? Only, so they're only, well, they're present in thin skin, not thick skin, right? And they secrete the sebum via the whole thing exploding. That's the holocrine method. They look like little popcorn kernels. Anyway, so that's alveolar morphology. Sweat glands are like a tube, tubular, coiled tubular. Maybe a question about that morphology. Oh, rector pili, those are cool, right? Smooth muscles associated with hair. And we'll come back to those when we talk about nervous system, which is pretty awesome. Skeletal tissues. All right, skeletal tissues. We've got cartilage and bone tissue. So hyaline tissue, it's a connective tissue. This hyaline and fibro and elastic cartilage, all of cartilage, do they have a blood supply built in? So, and that's called what? Avascular. Do they have any nerves in there? No. That's the only tissue that's both avascular and non-innervated. By the way, don't forget the epithelium is also avascular but innervated, right? This one's a little hurt. So cartilage. Chondral cartilage. Bone osseous. Hueso if you speak Spanish, right? So cartilage chondral. What do you call the outer covering of cartilage? Chondrium, right? And there we have the cartilage builder cells. Those are called, remind me, I forgot, chondroblasts. And then they retire within lacuna as chondrocytes. Beautiful. Locations we already talked about. Hyaline, pretty much everywhere. For more elastic fibers there, epiglottis, ear, right, all the E. And fibrocartilage, what's the word you want to remember? Disc. Intervertebral disc, interpubic disc, articular discs. Articular discs are fibro. Not articular cartilage, that would be hyaline. What are they doing over there? Shut up. Okay, I'm sorry. All right, so we've got, okay, oh yes, growth. So don't get confused on this. So when cartilage grows, it could either be from outside in, so the chondroblasts are making more of that appositional growth, or chondrocytes from inside interstitial. Cartilage growth from outside opposing ends, appositional growth, that's where we have the chondroblasts. From within, interstitial growth. And who's there? The retired guys, right? So they're still working. Appositional, interstitial. In the case of bone growth, we have either within a pre-existing hyaline cartilage membrane, endochondral, right? Or soft spots, mesenchyme, would be intramembranous ossification. One more time. So bone growth would be either in endochondral within hyaline cartilage. Then you have the growth plates. That's true for pretty much all bones, except for skull bones, most of those, and the clavicles. Clavicles are so special, right? And these bones, skull and clavicles, form within a pre-existing mesenchyme membrane, intramembranous. And we talked about the soft spots and things like that. Endochondral, hyaline cartilage, most bones. Intramembranous, skull, clavicle, mesenchyme membrane, intramesenchyme, you would call it, right? Now, bone tissue, osseous tissue, we have three types of cells. We have osteoblasts, osteocytes, and osteoclasts. So the blasts and the clasts live either on the outside within the periosteum, beautiful, or inside membrane endosteum. One more time. The osteoblasts and the osteoclasts, the builders and the breakers, they hang out together, hopefully in harmony, right? Otherwise, get osteoporosis, whatever. So on the outside would be the periosteum. Don't forget Sharpie's fibers. I love those. It's going to be on there. Sharpie's fibers, collagen, connect the periosteum to the bone tissue, right? Now, as far as types of bone tissue, compact or dense, we've got the long cylinder type things called osteons or Haversian systems, right? It's got the canal in there. It's got the lamella, right? And then we have Swiss cheese, the spongy bone. Then we have the trabeculae, and between those would be the marrow spaces, either red or yellow, depending on where that spongy bone is residing. Locations, we got this, right? Long bones, yeah, we got all of that. And then finally, joints. All right, so maybe take some notes on this, make flashcards or whatever. Don't forget that we have locations. Yeah, okay. So we concentrated on the knee joint. That's really the only synovial joint in a lot of detail. Maybe just one or two questions on that, right? But we also have fibrous joints and cartilaginous joints, right? Fibrous joints, remind me what would be our options. We've got the sutures, become synostoses. Then we have syndesmosis, distal tibiofibular joint syndesmosis. Oh, got teeth. Gumphoses, right? So sutures, syndesmosis, gumphoses. No joint cavity, right? Then we have cartilaginous joints, cartilage but no joint cavity, right? And cartilaginous joints would be synchondroses, hyaline, and symphysis. And we have the discs, right? So that would be fibrocartilage. All right, so back to synchondroses, hyaline cartilage. We have temporary, here today, gone when you stop growing in height. Epiphyseal plates go away, become the length, right? The only example, a good example of a permanent synchondrosis
Is the clavicle.
first
Okay, first rib.
rib, first sternocostal articulation. All that stuff should be in your notes, I believe. And then finally, we've got synovial joints, right? So we've got synovial joints, it's got the joint cavity, it's got the synovial membrane, which produces the synovial fluid. And last but not least, on the knee joint, flexion and extension. Oh, I do have one or two questions on muscle actions or actions at joints. Flexion, extension, abduction, adduction. Circumduction would be describing a cone, right? Putting all those things together. And there's something, elevation, up, depression. Soles of the feet in, inversion, soles of the feet out, eversion. There's something.
Protrusion.
Huh? Oh, yeah. I'm glad I'm wearing a mask. The protraction and retraction, I do that. Painful. Did I miss something? Huh? Oh, yes, thank you. Perfect. So when you plant your foot down, it's plantar flexion, and the back of the foot up would be dorsiflexion. On the knee joint, thank you. On the knee joint, what do you call the intracapsular ligaments, please? Cruciate ligaments, anterior and posterior cruciate. The main knee joint ligament in the front would be the patellar ligament, in the back, popliteal ligament. Arcuate and oblique sections, medial and lateral collaterals, menisci, articular discs. What do? Deepen that articular surface of that tibial plateau. Cushion and all, do all that good stuff. I think we're good. Are you guys feeling good about this? The answer should be yes.
Yes.
All right. So just to recap, hold on. We've got 5 minutes. Somebody might have a wonderful question that everybody might benefit from. Nope. What? Okay. So listen up. If you came in a little late, you cannot use any book. No. So it will be an open book, this one, because I feel bad for everybody. I'm going to try to look into the lights because it's really giving me a headache. And I know it's because that thing is when is the midterm? Wednesday, what time? 9:15? What kind of score are you gonna get?
100.
34.
Thank you.